Welcome to the Deep Dive. Today we're tackling really one of the most demanding but also incredibly rewarding challenges in plastic surgery, upper limb replantation.
Absolutely.
I mean, picture this. You're in the OR, you're facing a traumatic amputation, could be a finger, a hand, maybe even a whole arm.
Yeah.
The pressure's huge, the clock's ticking like mad, and, the responsibility to restore that limb, it lands right on your shoulders.
It really does. It demands that perfect blend of technical skill and sharp judgment.
Exactly. And for you, our listener, maybe you're a resident really working on those microsurgical skills, or perhaps you're an attending who faces these high-stakes cases pretty regularly. This deep dive is all about those practical tips, things that genuinely improve efficiency and success rates.
Right. We're not just talking how to do it, but exploring that critical decision-making under pressure, from the first assessment all the way to long-term patient outcomes.
And always keeping an eye on those absolute indications and, well, the controversies that still exist.
Precisely. We've been digging deep into a comprehensive review from the W Institute for Hand and Reconstructive Microsurgery.
Yeah, great source material.
Really trying to pull out the latest evidence, the surgical pearls. Basically, the stuff you can use right away.
Insights for the OR, for patient care, and maybe even a little edge for board prep, right?
Hopefully. Our goal is to really connect the dots for you link those intricate micro techniques to the functional results that actually change lives.
So we're focusing today on those absolute indications, where replantation is almost always the go-to.
That's the plan. We're talking the thumb, multiple digits, transmetacarpal amps, most wrist and forearm injuries too.
Okay.
And we'll definitely get into some specifics like single-digit replants in kids or, individual digits cut distal to the FDS insertion. That's where it gets really interesting.
All right, let's start small then, but hugely significant.
Right.
Very distal digital replantation. So
Yeah.
anything distal to the DIP joint.
Right. Tiny stuff.
What's so interesting here is the literature, it seems pretty consistent, doesn't it? It really supports replantation at this level.
It does. Higher success rates, better function, better cosmetic results compared to just doing a revision amputation.
So if the data looks that good, why isn't it just always an absolute indication for everyone? What makes it absolute for some, but maybe not others?
That's a fantastic question because it really brings in the patient factor, doesn't it?
Mm-hmm.
While the overall prognosis is good, the decision often boils down to specific patient needs and profiles.
Like who specifically?
Well, definitely children. Aesthetics are often paramount, and their healing capacity is just phenomenal, making replantation really successful.
Yep.
And then you have individuals where full finger length is critical maybe professionally, like musicians or artists.
Right, makes sense.
Or just patients with really strong aesthetic concerns. For those groups, it becomes an absolute indication. The intensive effort is justified by the high-value outcome they receive.
Okay, so let's get practical. A resident's facing these incredibly tiny vessels in the OR. What are your top tips? How do you find what you need down there?
Good question. Anesthesia, first brachial plexus block, local block, both work well.
Okay.
Technically, the key is successfully finding that central artery. It's the largest terminal branch off the distal transverse palmar arch, Ishikawa zone 2. That's your main landmark.
Got it. Central artery, zone 2.
And if you need more length, don't be afraid to reverse the distal transverse palmar arch. It's actually a very reliable trick.
Okay.
But honestly, the biggest challenge and the most common reason for failure is usually venous drainage, getting good outflow.
The veins. Always the veins.
Always. A really critical pearl here is to think regionally. Distal to the DIP joint, the veins are often larger on the palmar side.
Oh, interesting. Palmar distal.
Yeah, but proximal to the DIP, the dorsal veins tend to be bigger.
Okay, so location matters.
Definitely, and a reliable spot to look. The distal venous arch, just lateral to the nail fold, you can almost always find something usable there.
That palmar dorsal distinction, that sounds like a real time saver.
Yeah.
But what if, best efforts, vein repair, just isn't possible? What are the salvage options?
Yeah, you need a plan B. And C, controlled external bleeding through a fish mouth incision is one option.
No.
Removing the nail bed can help too. Or using medical leeches.
Leeches, still a thing.
Still a very effective thing. But always remember, if you use leeches, you absolutely need fluoroquinolone prophylaxis. Aeromonas hydrophila infection is a real risk.
Right, crucial point, prophylaxis with leeches.
Definitely. And you've also got continuous infusion with heparinized saline or even coming back for a delayed venous repair later. Keep those in your back pocket.
Good to have options. Okay, let's shift gears slightly, move a bit more proximally. Single-digit zone 2 amputations.
Ah, zone 2, no man's land, traditionally.
Exactly. Proximal index finger or proximal to the FDS insertion. Used to be that revision amputation was often just seen as the standard, right?
That was the classic teaching, yes. Concerns about poor sensation, stiffness, overall function being downrated.
But that thinking is really being challenged now, isn't it? What's changed?
It absolutely is. I mean, modern microsurgical techniques have improved dramatically.
Sure.
And we also have a better appreciation for patient-specific needs. If a patient strongly desires a longer, more aesthetic digit, maybe for cultural reasons or just personal preference,
Mm-hmm.
replantation can actually offer very satisfying results, both survival and function.
And what about the cost? I know that comes up.
Yeah, and interestingly, from a medical economic standpoint, some studies are even suggesting single-digit replantation can be cost-effective compared to revision amputation in certain scenarios. It challenges that old assumption.
That's fascinating. So sticking with zone 2, dealing with those flexor tendons, what are the key techniques, the pearls maybe for residents, especially thinking board prep?
Okay, flexor tendons in zone 2, they're definitely more approachable now. Techniques like wide-awake tendon surgeries, stronger repair methods, they've made a difference.
Right.
A really key strategy. Consider repairing only the FDP, the profundus tendon.
Just the FDP.
To minimize adhesions with the FDS, it can really gum things up.
Ah, makes sense. Less scarring potential.
Exactly. Now, if the distal FTP itself is badly damaged, you can attach the proximal FDP from the amputated part to the distal FDS tendon on the stump. That's a viable workaround.
Okay, good trick.
And crucially, vent the tendon sheath or a pulley just about 1 centimeter near the amputation level. That lets the repaired tendon glide more smoothly.
Okay, venting the sheath. Got it.
But here's a massive caveat, a real non-negotiable point for decision-making.
Okay.
If you cannot repair the radial digital nerve, replantation is generally contraindicated.
Why specifically the radial?
Poor sensation recovery there is strongly linked to decreased hand dexterity. Patients are often quite dissatisfied if they don't get good feeling back on that side.
Okay, that's a critical decision point. No radial nerve repair, probably no replant.
Generally, yes.
Let's talk kids. Pediatric replantation, this always feels like a different beast, you know? Tiny vessels, higher risk of vasospasm.
Totally different ball game.
Yet the functional outcomes can be just astoundingly better than in adults. What is going on there? What's the magic?
Yeah, the magic is really their incredible biology. Kids just heal differently.
How so?
Quicker soft tissue healing, much less scar formation, way better nerve regeneration.
Oh, wow.
Tendons glide better, joints mobilize easier. It all adds up to these superior functional results.
Even though they often have nastier injuries.
Yeah.
Crush, avulsion.
Exactly. Despite a higher incidence of those complex injuries and maybe slightly lower survival rates sometimes compared to adults,
Okay.
the reported success rates, functionally speaking, in pediatric digital replants, they're as high as 95%.
95%. That's incredible.
It leads to really high patient and parent satisfaction, and that's why the effort, the comprehensive effort, is almost always worth it in kids.
Okay, so a residence in the OR, pediatric case. Let's talk bone fixation and post-op care. What are the absolute must-dos?
Right. For bone fixation in kids, rule number 1, minimize shortening. You have to preserve those epiphyseal growth plates.
Critical for future growth.
Absolutely. Simple K-wire fixation is usually the way to go.
Okay.
And if you absolutely must cross a growth plate, use a smooth K-wire, never a threaded one. Minimize that potential injury.
Smooth K-wires across growth plates.
Got it.
And post-op.
Post-op, sedation is key. Keeping the child calm, even a little drowsy, is incredibly effective at preventing vasospasm. That's a big enemy in pediatric cases.
Makes sense. Keep them calm, keep the vessels open.
Exactly. And if you protect those growth plates well, digits can often reach 81–90% of their normal length. That's a fantastic outcome.
Truly remarkable. What about amputations right around the joints? Periarticular. The review mentioned a really core principle for these.
Yes, a really fundamental principle. For any periarticular amputation, the mantra is always think about preserving the joint over fusion.
Always try to save the joint.
Always. Now, for the DIP joint, okay, arthrodesis fusion can give good function and look okay. But even there, if you can preserve it, you try. For DIP fixation, you'd use 1 or 2 K-wires through the distal tip, volar to the nail, push them proximally. But crucially, do not cross the PIP joint with those wires.
Don't cross the PIP. Got it. And for PIP and MCP joints?
Preservation is absolutely paramount there. Techniques like a modified 90-90 wire with an interarticular loop wire, it acts like a little internal splint that can be really helpful for saving the PIP joint.
Interesting techniques.
Even way up at the elbow. If the joint surface is intact after an amputation, you can do temporary K-wire fixation, maybe with an external fixator, to preserve that potential function. Then later, you come back with free-functioning muscle transfers to reconstruct motion.
So always thinking long-term function, preserving that joint potential.
Exactly. Joint preservation first.
Okay, let's tackle the really tough ones. Avulsion and degloving injuries. Notoriously difficult, right? Massive soft tissue damage, messed up neurovascular structures.
Yeah, these are definitely challenging. They really test your creativity.
So what are the core strategies? How do you even start?
Well, for degloved fingers, finding usable vessels can be a real hunt. Sometimes you literally have to turn the skin inside out carefully,
Wow.
or maybe use a zigzag volar incision to explore. Reducing skin tension is also vital, especially if you've done any bone shortening or disarticulation.
Makes sense. Less tension on the repairs. Is there a best-case scenario for replanting these messy ones?
Sort of a sweet spot, yeah. Often it's a digit avulsion that also has a fracture or joint injury, but it's distal to the FDS insertion,
Okay.
and the PIP joint is still intact. That combination often gives you the best shot.
Intact PIP is key.
Very key. For arteries, you're often looking at long vein grafts, interposition grafts, or maybe borrowing a digital artery from the next finger over.
Rotary transfer. Okay.
And if you just can't find good arteries, arteriovenous shunting is an option. And flow-through venous flaps are great because they can fix the vessel problem and the soft tissue defect at the same time.
Right, solving two problems at once. Beyond the vessels in these avulsions, nerve management feels critical for usable function long-term.
Oh, absolutely critical. You can have a surviving finger that's essentially useless without sensation.
So what are the decision points there? What must be done?
While getting both digital nerves isn't always possible, you must reconstruct at least one digital nerve. Mandatory for protective sensation, especially on the pinch side.
One nerve minimum. And how best to do it?
Nerve transfer is generally preferred. Taking an intact proximal digital nerve and connecting it to a distal digital nerve in the replanted part works better than using a nerve graft harvested from the avulsed nerve itself, which is often damaged.
Okay, transfer over graft if possible. What if you need a graft source?
Last resorts. Terminal branch of the posterior interosseous nerve, or maybe a branch of the medial antebrachial cutaneous nerve.
Got it. And managing pain afterwards. Neuropathic pain could be a real issue.
Huge issue. Ensuring a completely tension-free nerve repair, the neurography, is step one. Sometimes wrapping that repair with a collagen conduit can be really beneficial in minimizing pain down the road.
Good tip. Okay, the thumb. It seems like the thumb is almost always an absolute indication, right? No matter how bad the injury.
You are absolutely correct. All traumatically amputated thumbs are considered candidates for replantation. Period.
Why the special status?
Because the thumb's function is just so profoundly critical for everything the hand does. Opposition, grasp, pinch. Losing it is devastating functionally and for quality of life.
So what are the key surgical points for thumb replantation?
Minimize bone shortening if you can. However, arthrodesis, fusing the IP or MCP joint, is actually more accepted for the thumb than other digits.
Really? Why fuse the thumb joints?
Because you want to guarantee useful motion through the CMC joint, the base joint. Fusing more distal joints can provide a stable post for that crucial opposition movement.
Ah, stability for opposition. Makes sense. Arteries.
The ulnar digital artery is usually the dominant one, the most reliable one to target for your anastomosis.
Ulnar digital artery. Got it.
Yeah.
Any technical tips for residents?
Yes, a really useful one for efficiency. Try anastomosing your vein grafts, if you need them, to the terminal branch of that ulnar digital artery before you do the bone fixation, the osteosynthesis.
Do the vessels before the bone. Interesting.
Can make access easier. And if possible, do the proximal anastomosis dorsally with the hand supine. Again, often easier access.
Great practical tip. And nerves for the thumb.
Just like single digits, at least one ulnar digital nerve must be repaired. You need that protective sensation for the thumb to be truly useful. Without it, its function is massively compromised.
One nerve minimum. Again.
Huh.
Okay, moving up in complexity, multiple digit amputations. Now the juggling act gets intense.
Yeah, complexity skyrockets here. Time pressure, multiple structures.
What's the strategic approach? How do you manage these incredibly demanding cases effectively?
Okay, 3 or more fingers involved. Meticulous attention to absolutely every single detail is essential. technique, preserving the parts properly, anesthesia, post-op care, everything.
And keeping the patient stable, obviously.
Patient vitals, absolutely paramount throughout. Now, sequence. If you've got prolonged ischemic time, a digit-by-digit approach is often better. Replant one, get it perfused, move to the next.
Okay, digit by digit for long ischemia.
But if the cold ischemic time isn't too bad and won't significantly impact survival or function, a structure-by-structure sequence can actually be more efficient. Fix all the bones, then do all the tendons, then all the arteries, etc.
Structure by structure for efficiency if time allows.
Got it. What about the order of fingers? Does it matter which you replant first?
Hugely important. You prioritize based on potential function. That means thumb first, always.
Thumb first. Makes sense. Then
Middle finger, then ring, then index, and finally the small finger.
thumb, middle, ring, index, small. Okay. And resist that temptation to drag out the surgery just to save every millimeter of length. Judicious bone shortening is often much better than using lots of grafts. It simplifies the repair and can improve overall function.
Okay, don't be afraid to shorten for a better overall outcome. What about those really tough situations, like the thumb just isn't replantable, or horrific bilateral injuries?
Yeah, tough scenarios. If the thumb is gone, the strategy becomes transpositional replantation. Meaning you take the least damaged remaining digit and you move it over, transpose it into the thumb's position.
Wow, replant a finger as a thumb.
Exactly. The goal is to restore at least basic pinch, tripod pinch, that critical opposition grip. Give them something functional back.
And for bilateral multi-digit amps.
There, the focus might be on restoring maximum dexterity in the dominant hand, or maybe just achieving basic hand function using transpositional techniques, or even, in extreme cases, cross-hand or cross-arm replantation.
Moving parts between limbs.
It's rare, but it's about restoring the most critical functions possible, even with unconventional means.
It's incredible. Okay, transmetacarpal replantations. Through the palm, basically.
Yeah.
Historically, these struggled with intrinsic muscle recovery, right?
That's been the major hurdle. Technically, they aren't the hardest replants to do, but the functional results were often poor because of intrinsic muscle damage and subsequent scarring.
So how do we combat that now? What are the pearls for residents?
Key strategy. To prevent that secondary intrinsic tightness and improve function, at least 1 centimeter of bone shortening is strongly recommended.
1 centimeter minimum shortening for transmetacarpal. Why?
It helps relax the soft tissues, including those damaged intrinsics. Careful bone fixation is also vital to prevent any malrotation.
Okay. Veins.
Venous drainage is critical here. You need to anastomose at least 3 or 4 dorsal veins, rough rule of thumb. About 2 veins for every artery repaired.
2 veins per artery. Got it.
And don't forget to ligate the little branches of the deep metacarpal arteries. Prevents nasty postoperative hematomas.
Good housekeeping point. What about the intrinsic muscles themselves?
Really important. Thoroughly debride any devitalized or denervated interosseous muscles. Then allow the intrinsic tendons to basically scar down, tenedies, in an intrinsic plus position.
Intrinsic plus kinedesis. And post-op management.
Super important here. Early protective active mobilization. Started around 72 hours post-op combined with anti-claw splinting. This is crucial patient management to prevent that dreaded intrinsic minus deformity and really improve their grasp later on.
Early mobilization anti-claw splint.
Yeah.
Crucial. Okay, highest stakes now. Major limb replantation. Wrist, forearm, elbow, shoulder.
Yeah, the big ones.
These come with serious risks, associated life-threatening injuries. Beyond the initial trauma management, what are the advanced strategies for success here?
Time is just absolutely critical. Getting arterial flow reestablished within 2 hours is the ideal. You really need to be cautious if the total ischemic time goes beyond 6 hours.
2 hours ideal, 6 hours is pushing it.
Big time. A fantastic time-saving practice is back table preparation. While anesthesia is getting induced, a separate team preps the amputated limb. Buys you precious minutes, even hours.
Back table prep. Smart. What else?
Radical debridement is non-negotiable, especially of the distal muscle mass. Infection is the most common and potentially lethal complication in major limb replants, and aggressive debridement is key to preventing it.
Debride aggressively. Got it. Any really innovative techniques for delayed cases?
Yeah, if OR arrival is delayed, say beyond 4 hours, there are options. Temporary ectopic banking, basically parking the limb somewhere else on the body temporarily.
Wow.
Extra anatomical cross-limb shunting to get circulation going quickly across limbs, and even extracorporeal limb perfusion.
Perfusing the limb outside the body.
Exactly, especially using something like University of Wisconsin cold storage solution with hypothermic perfusion. It can buy you significantly more time for preservation and allows for really precise preparation. Extends that window.
Amazing technologies. Okay, you're in the OR, actively reattaching a major limb. What are the key surgical decision points, the clinical applications?
Aggressive bone shortening is usually necessary for good functional restoration. Think 2.5 to 5 centimeters for the radius and ulna,
Okay.
maybe 6 to 8 centimeters for the humerus.
Significant shortening.
Yeah, it allows for tension-free nerve and vessel repair. You'll want to repair 2 main arteries along with their venae comitances, their accompanying veins,
All right.
and at least 2 major subcutaneous veins as well.
2 arteries, matching veins, plus subcutaneous veins.
Okay, after you get arterial flow going, let the vein bleed freely for about 5 minutes. Helps flush out toxins.
Flush for 5 minutes. Got it. Systemic risks.
Be prepared for potential hypovolemic shock. And if that ischemic time was over 6 hours, or there's a lot of muscle mass involved,
Sure.
this is critical.
Okay.
Administer sodium bicarbonate slowly, IV, over 5 minutes before you release the clamps, with continuous ECG monitoring.
Bicarb before reperfusion.
To manage the metabolic acidosis, the hyperkalemia, the whole reperfusion injury cascade that can hit the patient systemically when flow is restored to ischemic tissue, it can be life-saving.
Critical pre-reperfusion step.
Nerve repair. If direct repair isn't possible, sometimes you have to get creative. Cross nerve sutures maybe hook up the proximal radial nerve to the distal median nerve just to get some protective sensation back.
Wow. Sacrificing one for another.
Or just tag the nerve ends carefully for delayed grafting later. And remember, secondary reconstructive surgery is almost always needed down the line for major limbs. Tenolysis, muscle transfers, soft tissue coverage. It's usually a staged process.
Right. Replantation is just the first step. Finally, this idea of delayed or suspended replantation, it kind of challenges everything we thought about ischemic time limits.
It really does. And the surprising thing is, for the right cases, this approach can give comparable survival rates and function to doing it immediately.
Really? Which cases?
Particularly well-preserved single-digit amputations that might present overnight.
Ah, the overnight finger case.
Exactly. The advantages are pretty clear, right? It takes the pressure off the team operating exhausted in the middle of the night, probably lowers costs,
Sure.
and allows the surgery to be done by a fully rested, fully staffed team the next day, which usually correlates with better outcomes.
Makes a lot of sense. Any other patients it's good for?
Yeah, it's especially relevant for patients who are unstable from other issues, severe heart or lung problems, maybe severe anemia. You can stabilize them first before taking them for a long, complex replant.
Okay. When is it not a good idea?
Generally less ideal for amputations proximal to the transmetacarpal level. Because of all those intrinsic muscles in the hand, they just don't tolerate prolonged ischemia nearly as well as a single digit does.
Right. Intrinsics are less forgiving. That's a really interesting shift in thinking about timing. Last points. Patient monitoring post-op and anticoagulation. What's essential?
Post-op monitoring. Honestly, intensive monitoring by experienced nursing staff just looking at capillary refill, temperature, color is often more reliable than relying solely on devices.
The experienced eye.
Exactly. If there's a circulatory crisis, don't hesitate. Re-exploration and re-anastomosis are often needed.
Be prepared to go back. Anticoagulation.
Standard regimen is usually pre-op aspirin, enteric-coated, and intra-op heparin bolus,
Okay.
and traditionally dextrin 40 infusion post-op, although some centers, like our source material mentions, are moving away from dextrin now due to potential side effects.
Right. Dextrin is becoming controversial.
It is. But here's the absolute most critical pearl about anticoagulation. Cannot stress this enough.
Okay.
Anticoagulants are useful adjuncts, but they can never substitute for a technically perfect, tension-free anastomosis.
The surgery has to be right first.
Absolutely. If the repair itself isn't good, no amount of blood thinner is going to save that replant.
Wow. Okay. That was a truly comprehensive deep dive.
Yeah.
Just packed with practical insights, critical decision points for residents, for attendings, everyone.
Yeah, covering everything from those tiny microanastomoses and distal digits all the way up to managing the huge systemic effects of major limb replantation. The complexity is immense.
And the responsibility is huge.
What's really fascinating, though, is seeing how the techniques and the indications keep evolving, right? We're
Yeah.
constantly pushing the boundaries of what we can do to restore function, improve quality of life,
It really is amazing.
mastering all these nuances, the bone shortening strategies, the nerve repair priorities, those crucial post-op protocols. It's just essential knowledge for any plastic surgeon doing this work.
It absolutely underscores that this field is such a unique blend of, incredible technical precision, sharp clinical judgment, and really deep patient-centered care.
Couldn't agree more.
So for you, our listener, what does this all boil down to? I mean, beyond just getting better technically,
Yeah.
it seems like the ability to strategically plan, to adapt when things inevitably go sideways in the OR, and to always, always prioritize those long-term functional outcomes. That's paramount.
Precisely. Couldn't have said it better. And maybe a final provocative thought to leave everyone with. Given that we see consistently high patient satisfaction rates, even in cases where the functional result isn't, objectively perfect,
Right, that's true.
how might our definition of success in replantation need to evolve? Should it maybe include a broader psychological perspective, a quality of life measure, especially considering how life-altering these injuries are?
Measuring success beyond just motor and sensory score.
Exactly, something more holistic.
That is a powerful question to think about as you navigate these vital limb-saving procedures. Thank you so much for joining us on this deep dive.